Postpartum hemorrhage, or PPH, is the leading cause of pregnancy-related death worldwide, with one estimated death every 4 minutes. Definitions of PPH include blood loss greater than 500 mL following a vaginal delivery, blood loss greater than 1,000 mL following a caesarean delivery, or any blood loss that has the potential for hemodynamic instability. Ideally, quantitative techniques rather than visual estimation of blood loss at delivery should be utilised. There are multiple risk factors for PPH, which can be categorised according to the various etiologies. 4 main causes of PPH are also known as the 4 T's. Tone, when the uterus does not contract well after the placenta is delivered. Tissue, when a piece of the placenta, membranes, or large blood clots remain inside the uterus. Trauma, when there are injuries to the vulva, vagina, cervix, or uterus. And thrombin, when there is a problem with blood clotting. Uterine atony is the most common cause, accounting for 80% of cases. Active management of the 3rd stage of labour is a critical step towards reducing PPH. Active management involves routine use of uterotonics and controlled cord traction for placental delivery, followed by uterine massage. First-line uterotonics, or medications that promote uterine contractility for the prevention of PPH, include either oxytocin 10 units administered intramuscularly at the anterior shoulder during vaginal delivery, or carbetocin 100 micrograms administered intravenously over 1 minute at caesarean or vaginal delivery with risk factors for PPH. Carbetocin is stable at room temperature and has been shown to be more effective than continuous oxytocin infusion for PPH prevention. PPH management requires early identification and treatment of the cause while maintaining hemodynamic stability. Abnormalities in or changes to a patient's vital signs may be important indicators of PPH severity. Optimal management involves a multidisciplinary approach with obstetrics, midwifery, nursing, and anaesthesia. Calling early for extra support is vital. First steps include ensuring adequate large bore IV access for fluids, medications, and possible blood products. A second IV is often indicated in severe PPH. Insertion of a urinary Foley catheter to decompress the bladder and help the uterus contract and to monitor fluid balance. And drawing baseline labs including hemoglobin, platelets, coagulation studies, and possible cross-match of donor-packed red blood cells. Definitive management can include medications, uterine compression, surgical management, and interventional radiology. There are 2 main categories for medical management: uterotonics and antifibrinolytics. Uterotonics promote uterine contractions to prevent and treat atony and encourage delivery of the placenta. Uterotonic agents for management of PPH include oxytocin, which is first line, carbaprost or hemabate, ergonovine or ergometrin, misoprostol, and sintimetrin, which is not currently available in Canada. Tranexamic acid is an antifibrinolytic agent that works by stabilizing blood clots. Postpartum hemorrhage kits with access to these medications should be easily available on all labour and delivery units. Compression involves applying pressure on the area of bleeding to decrease blood flow. Compression is mainly used to treat uterine atony, but may be considered for other causes of bleeding. Two commonly used techniques for non-surgical uterine compression are bimanual uterine compression or massage and intrauterine balloon. Bimanual massage and compression of the uterus is a rapid and effective method to treat atony. One hand is placed in the vagina to apply pressure to the anterior lower uterine segment, with the other hand placed over the uterine fundus abdominally. Consistent compression between the two hands helps to reduce blood flow. Manual removal of clots can also be completed during this maneuver. When uterotonics and bimanual uterine massage are ineffective, intrauterine compression with a balloon may be considered. An intrauterine balloon, such as the Bacry postpartum balloon or 14 French Foley catheter, can be placed inside the uterus to provide direct compression to tamponade the myometrial vessels. These balloons work most effectively when the uterus has adequate tone. A Foley catheter is simultaneously inserted into the bladder to monitor urine output, facilitate voiding, and improve patient comfort. Usually the balloon is inserted vaginally, and point-of-care ultrasound may be used to guide placement and inflation where available. With 2 fingers placed through the cervix, the balloon catheter is directed to the uterine fundus. Once correctly positioned, the balloon is inflated with sterile fluid to the maximum pressure required to mitigate bleeding. Avoid overinflating the balloon, as this may result in displacement. When the cervix is dilated, the vagina can be packed with iodine or antibiotic-soaked gauze to prevent balloon expulsion from the uterus. A metered catheter bag is attached to the drainage port to monitor blood loss. The balloon is removed within 24 hours and prophylactic antibiotics are recommended during this time. When placed during caesarean delivery, the balloon is inserted through the hysterotomy and the tubing is passed through the cervix into the vagina. The uterine incision is then sutured closed, with care not to puncture the deflated balloon. At this point, the balloon is inflated. An alternative approach is to place the balloon vaginally after the uterus is closed.